we had a question from Dr. Almeida from the UK. Thank you so much, Doctor, for your question. He's asking which group is Dr. Rossi talking about. So I just remind, so there are 5 groups in IMCAS Alert, one for lasers, one for injectable, one for genital, one for plastic surgery, and one for clinical dermatology. So Dr. Rossi has been reviewing some cases related to the clinical dermatology case, and obviously he has selected derm surgery cases as we have just saw. Okay, I hope that this answers your question. We had a question also from Dr. Semedo from Portugal. I'm not sure, Anthony, whether you will get it, but that was a question, very simple. What about antibiotics? Does it relate something, Anthony?
So for straightforward PDT, I don't give antibiotics to everyone. So only in the case like that I showed that had the impetiginized crust or the yellowish crust on the face, if I see that happening, then I will give antibiotics both orally and topically. But I also teach them how to do more diligent, wound care of the face using the dilute acetic acid or white vinegar and warm water. That way they can really get rid of some of that crusting. But if I do see that impetigo starting to happen, I will give sort of like a 3rd generation cephalosporin that will cover staph well. But I don't give it routinely, just prophylactically.
And you give it after procedures?
After, yeah.
Yeah, okay, because that was the second part of Dr. Semedo from Portugal question. He was mentioning post-procedures. Okay.
I have a comment to that.
Please.
I do a lot of peelings. I don't do any PDT, but at the end it is also a destruction of the skin, and I think that the control of the patients, the aftercare control, is extremely important. I never give. I don't remember when I ever gave systemically antibiotics. A little bit of impeginization. This you can deal with fusidines acid in a topical treatment. I never give corticosteroids as well. So sometimes you have an inflammation and you tend to do, we want to get a little bit rid of this inflammation, and then you give corticosteroid. This is a little bit against the effect. On the contrary, I think the valacyclovir is extremely important, because if once you have an erosion of the whole face, and then you're facing a herpes on the whole face, this is really an emergency for inpatients. Antibiotics is not that important, I think, in the field of peelings. I don't know, Anthony. You do systemic as well?
No, I don't do systemic. Only if they really do have a true infection that I culture and it shows, a pathogen, not just Staph epidermis, but something like Staph aureus. But I do agree with you. So I don't give prophylactic antibiotics. I very rarely ever have to give antibiotics post procedures, or, I do a lot of peels and laser ablation as well. But I do agree that most everyone will get a prophylactic antiviral, especially if we're going around their mouth. And I usually start 2 days before the procedure. I don't know what everyone else does, if they start the day of or if they start before.
Day itself.
Okay, nice.
Doctor,
which makes it easy for the patient.
Dr. Turki, do you want to comment on this use of antibiotics? You are muted. You are muted.
No, I never give preventive antibiotic in my dermatology. I just have problem. I haven't in 35 years practice. I have 2 sepsis, only 2 sepsis, because it take there is material like Dr. said. But my question for Dr. Olivier, you give preventive antibiotic in dermatology?
No, also antibiotics is also, as I just said, antibiotics is when you fear that you come into a complication, then I start with topical antibiotics, and then most of the case, no, then every case is actually solved.
So when you have a diabetic patient, you give
A
systematic.
diabetic, okay. Yes, no, actually no. When this is only a risk factor, and if the diabetic patient is going well with the peel, no, I would not say. Also, laser, fractional laser, ablative lasers. If you do a good wound care, I think the problem is solved.
I agree with you. Don't give a corticosteroid topic. All my laser, I never give corticosteroid because to have herpes or patient, don't distinguish herpes or not herpes. And sometimes when I prescribe corticosteroid, topical corticosteroid, they continue to applicate corticosteroid.
Mm-hmm.
Think so?
Yes.
So?
If you apply, then you take the effect. I always say my patients, the erythema is our friend, not our enemy. Yep.
Okay, great.
Yeah. I do think just another case in point, like not only for the photodynamic therapy, but also for lasers and peeling, if the patient is not healing properly and healing slowly, and they do have a history of herpes, you know, I have a very low threshold to culture and just make sure they're not spreading, you know, like a herpetic lesion on the face.
You.
Anthony, we have a question that I've selected. It doesn't appear on the live, so I'm going to read it. Here it is. Where the PDT session continue for the same patient that experienced milia? Yeah,
so we kept going with the PDT. And the milia was really because she was using such heavy petrolatum ointments and didn't transition to a lighter moisturizer earlier, that she just, when the skin re-epithelialized, it sort of made a lot of occlusive milia. So those were easily extractable, and we just switched to a lighter moisturizer.
In general, if you peel the patients, then you are facing a lot of milias, and this is some transient problem. This will go by itself. It peels off then, and then when you have the first epithelialization, then it may be occurring. So a milia is for me actually not a complication. I would certainly do again a PDT on these patients.
Yeah, and peels too, right? Like
yes, and peels. Yes, of course. Yeah.
Do you often operatively make them do a retinoid to try to exfoliate them more, or?
The point is the whole skin is already irritated, and if you come now with tretinoin or another retinoid, then probably you do a little bit too much. For me, I think we have to wait, and this problem will solve by itself.
I have a question for Dr. Perez. Dr. Perez, how do you see the future between OCT and confocal microscopy? Will it remain how they can live together? What is your opinion? I think it's a difficult question, but let's think about it.
It's a very difficult question. But at least if we don't have the complete Viva block, we really need the RTM with the confocal, because confocal has a long trajectory period, a lot of experience. OCT, it's a novel technique.
Yeah.
But I think if they continue in the same way, we're going to have very, very nice results.
Okay, so I think that we have to wait a couple more months or years in order to have the answer.
Yeah, they are doing great. This is what I can say.
Okay, thank you so much. Is there any other question from the faculty to Dr. Perez? No? Okay, so I think this is time now for me to conclude this webinar. First, I would like to thank you, the faculty, for being there to take the time. I mean, IMCAS Academy is dedicated to education, and what you are doing is a fantastic is a masterpiece of education to the doctors which has been able to attend. We need to bear in mind that this webinar is going to be accessible via a replay version. So if people were not able to attend, they will be able to access it. So thank you so much for being there and have taken the time out of your clinic to tell us more about those complications and various indications as for dermatologic surgery. And I would like to thank you also the IMCAS team. And last and not least, this is my last slide. I would like to remind you that in a couple days, in a couple weeks, IMCAS World Congress 2023 is held in Paris from the 26th to the 28th. This is a massive gathering. Over 40,000 doctors will be there. A lot of course, a lot of education again. So if you have the chance to join us in Paris, you'll be most welcome. If you want to have more information concerning the Congress, you have just to log on imcas.com. So thank you very much. This is the end. Thank you, Anthony, for sharing this webinar, and thank you all of you. Thank you and bye-bye.
Thank you so much.
Thank you.
Thank you.
Goodbye.
See you
Bye.
soon.
Good night. Good
Bye-bye.
night.
Bye.